Good morning everyone. Today I am presenting JC on lobular carcinoma breast metastatic to the ovary, a clinicopathologic study of 38 cases. This study was done by Ying Chong et al. In the Department of Pathology, Ku Foundation, Sun Yat-sen Cancer Center, School of Medicine, College of Medicine in Taiwan. This article is selected from American Journal of Surgical Pathology. Metastatic breast cancer to the ovary has historically received considerable attention dating back to early studies on metastatic tumors to the ovary in late 19th century. Work on metastatic tumors to the ovary over the last few decades, it has very much focused on metastatic colorectal tumors and metastatic mucinous tumors from diverse sites such as pancreas, appendix and uterine cervix. There has also been considerable attention given to the use of IHC as a diagnostic aid in distinguishing primary from the metastatic ovarian tumors. Lobular carcinoma shows a great propensity to metastasize to the gynecologic tract than ductal carcinoma, although metastatic ductal carcinoma are encountered slightly more frequently due to their greater incidence. Materials and methods. Cases of pure invasive lobular carcinoma and invasive lobular carcinoma with minor ductal differentiation metastatic to the ovary were retrieved from the institutional and personal consultation files. All available H&E stain slides were reviewed. Histomorphologic features were evaluated, including growth pattern, nuclear grade, Scapulum-Richardson grade, stromal reaction, ovarian surface involvement, lymphovascular invasion, necrosis, and presence of coexisting ovarian primary tumor. Result of IHC staining, if performed, as well as gross features including laterality, size, cut surface appearance were noted. Results: 38 cases were retrieved. All patients had a history of breast cancer as confirmed by consultation note or prior or subsequent pathology report and review of patient's breast pathology slides. 22 of the primary breast tumors had known lobular features. In this table, the clinico-pathologic features of metastatic lobular carcinoma to the ovary, we had age ranging from 39 to 91 year and prior diagnosis of breast cancer were 31 cases, and in 30 cases it was bilateral involvement, and in 27 cases it was multinodular growth, and in 15 there was surface involvement of the ovary. Among coming to histologic patterns, most of the cases showed diffuse or solid growth followed by single cells and delicate cords in 28 cases, and in 19 cases these cells were in small nest or clusters, and nuclear grading was given. Among these, maximum cases were in grade 2 and singles signet ring cells were seen in 9 cases. Necrosis was noticed in 3 cases and prominent stroma was noticed in 17 cases. Vascular invasion was noticed in 8 cases. Gross findings. Gross evidence of ovarian involvement are observed in 28 cases. It was bilateral in 22 cases and unilateral in 6 cases. The cut surface was predominantly solid with cystic noted in only 1 case. The solid component was most often nodular. When noted, it was firm and moderately soft. The sectioned surface were variably white to yellow tan to pink tan. This is the gross picture appearing metastatic lobular carcinoma. Here we can see multinodular solid tan white mass. Coming to microscopic features, here multinodular growth was seen in 27 cases. The tumors demonstrated a range of patterns including diffuse or solid growth in 33, single cell pattern in 33, cord-like arrangement in 28, small nests and clusters seen in 19 cases. Of these, 5 cases with minor ductal features, all 5 demonstrated focal tubular growth and 1 displayed focal cryptiform growth. The ovarian surface involvement was documented in 15 cases. Necrosis was seen in only 3 neoplasms, accounting each for less than 5% of the tumor area. Nuclear grading was done and in grade 1 seen in 2 cases, grade 2 in 32 cases, grade 3 in 3 cases. And using modified Nottingham's Kaplan-Richardson grading system, 5 were grade 1, 31 were grade 2 and 2 were grade 3. The degree of stromal reaction varied from none to marked, with 17 of 38 cases demonstrating at least a focal marked stromal response. Calcification was present in stroma in 4 cases but was not conspicuous in any of them. 2 tumors showed moderately prominent inflammatory cell reaction of lymphocytes and plasma cells. The results of special strains and IHC studies, including those for estrogen receptor, progesterone receptor, and human epidermal growth factor receptor 2, breast biomarker study shows ER positive in 10 cases, PR positivity seen in 7 out of 9 cases, and human epidermal growth factor 2 expression was seen in 1 case out of 5 cases. Here in this microphotograph we can see the tumor cells arranged in a nodular pattern, and in the picture P we can see they are arranged in diffusely. Here in the first microphotograph we can see the tumor cells arranged in delicate cords of the primary lobular carcinoma. In figure 2 we can see the tumor cells which are arranged in nests and clusters. In this microphotograph, in first picture, we can notice there is focal tubular growth in minor ductal components, and second microphotograph, we can see tumors which are having abundant eosinophilic cytoplasm, and there is a marked nuclear pleomorphism which is a variant of pleomorphic lobular carcinoma. In this microphotograph, in figure A, we can see this one tumor cells with abundant eosinophilic cytoplasm with intermediate grade situated in the hilum, and in figure B we can see single cell infiltration which are present in the parenchyma. The findings raised a differential of Leydig cell tumor with associated stromal hyperthecosis. Coming to discussion, the breast carcinoma accounts for majority of metastatic tumors to the ovary when both autopsy and surgical pathology material is considered. Distinguishing metastatic breast cancer from the primary ovarian neoplasia remains a highly relevant clinical issue. Patients with hereditary breast and ovarian cancer syndromes are at risk for both forms of neoplasia, and proper distinction is critical for appropriate therapy. BRCA1 mutation carriers most often develop high-grade duct breast carcinoma, while BRCA2 mutation carriers can develop either duct or lobular carcinoma. The lobular carcinomas are morphologically distinct from the typical high-grade serous carcinoma of the fallopian tube and ovary that occur in BRCA1 and BRCA2 patients. But diagnostic issues can occasionally arise. The remoteness of the history in such cases can make metastatic cancer seem unlikely or obscure the relevant information from the pathologist. It is the purpose of this study to review the experience with metastatic lobular carcinoma to the ovary to aid in diagnostic recognition by focusing on the histomorphologic features distinctive for lobular carcinoma diagnosis. Lobular breast carcinoma metastatic to the ovary warrants independent exploration from the metastatic ductal carcinoma for a number of reasons. First, of metastatic breast cancer, a higher portion of the lobular carcinoma demonstrate ovarian involvement than the ductal carcinoma. Second, most lobular carcinoma is more likely to present as ovarian cancer than ductal carcinoma. Bilateral ovarian involvement was frequently seen. Many cases also demonstrated a multinodular solid gross appearance. Of note, both the gross necrosis and cystic appearance that typify many cases of metastatic gastrointestinal neoplasia were largely absent in our cases of metastatic lobular carcinoma. Microscopically, the presence of characteristic lobular features, dispersed single cell growth, and delicate cords were diagnostically distinctive, and as were the cytologic features of the neoplastic cells. The morphologic appearance of metastatic lobular carcinoma raises a fairly broad differential diagnosis, largely dependent on the predominant growth pattern within the metastasis. In this table, we can see various differential diagnosis of lobular carcinoma METs. The diffuse and solid or nested pattern also seen in primary ovarian epithelial cells, but it is different from the lobular carcinoma in nuclear pleomorphism, glandular or papillary formation, cohesive growth, and elevated mitotic activity. For the special stains, it is positive for the PAX8 and WT1. Second DD is adult granulosa cell tumor. Here it is differentiated from lobular carcinoma by longitudinal nuclear grooves, angulated nuclei, fibrothecomatous stroma, Karl-Exner bodies, and it is positive for inhibin, calretinin, FOXL2, and SF1. Third, it is metastatic malignant melanoma. Here we can see nuclear pleomorphism, melanin pigment, and it is positive for melan A and HMB45. In metastatic ductal breast carcinoma, here we can see heterogeneous growth patterns, cohesive growth, and glandular differentiation. In Krukenberg tumor, we see tubuloglandular differentiation, intestinal type of epithelium, extracellular mucin pools, dirty necrosis, and it is positive for CDX2. The cords-like arrangement is seen in Sertoli Leydig cell tumor, carcinoid tumor, desmoplastic small round tumor, and lymphoma or leukemia. In Sertoli Leydig cell tumor, we can appreciate Leydig cells, and these are positive for inhibin, calretinin, FOXL2, and SF1. Carcinoid tumor, we can see trabecular growth pattern, more than one cell thick salt and pepper chromatin, and it is positive for chromogranin and synaptophanes. Desmoplastic small round cell, here we can appreciate the clinical presentation of young women with bulky abdominal disease, and it is positive for desmin and WT1. Lymphoma or leukemia, we see fibrotic and sclerotic background with positive for the LCA, that is leukocyte common antigen. Coming to abstract, they evaluated the clinicopathologic features of 38 cases of metastatic lobular or predominantly lobular carcinoma involving the ovary. The patients were from 39 to 91 years. In 2 cases, breast, primary, and ovary metastasis were diagnosed synchronously. And in 5, the breast primary was only discovered after metastatic carcinoma in the ovary was found. In majority of cases, both ovaries were involved. The mean ovarian tumor size was 5.9 cm. The ovarian tumors demonstrated a range of patterns include macronodular, diffuse, single cell infiltration, cords, and small nested clusters. 9 cases demonstrated focus signet ring cell morphology. The associated stromal reaction ranged from nut to marked, with almost half of the cases demonstrating a marked stromal response, largely prominent sclerosis. A variety of neoplasms, most typically sex-cord stromal tumors, lymphoma, leukemia, desmoplastic small cell tumors are for the differential diagnosis. Thank you.